I thought we could start. So what kind of virus is HIV? We're just gonna warm up. So it's a retrovirus. Do you guys know anything else? Was somebody with me the other day? I was talking about how it's also. So what's a retrovirus? What does that mean?
RNA code to create DNA.
Exactly. Okay. It's also a lentivirus. Have you guys heard that word before? Okay, good. What does that mean?
It's like it stays dormant.
So what is lenta in Spanish? The Latin, huh?
Like slow.
Slow, right? So it's super slow. It's actually really smart in that way, in that it has this really long incubation period. So imagine living in the 80s, in the early 80s, and you're an epidemiologist and you're trying to figure out how to identify these cases. Think about that, right? What was the problem? Why was it spreading like fire and we couldn't stop it?
People that have symptoms for a while.
You're right, asymptomatic. Because most people, when they actually get AIDS and really sick, they're probably not having sex anymore, right? So, but when you're spreading it, you're asymptomatic, and that period of being asymptomatic could be 10 years, could be 5 years, right? So think about trying to identify cases when you don't even have a test for it, right? And then you're trying to do this. So, and then just a little bit of more background on, you guys don't want to come here? You two back there? I can't even see your face. Yeah. We're gonna, because I'm gonna split the room later for questions, right? So we'll do. I'm not gonna ask twice. So a little bit of background. Do you guys know how this first came into humans? I just think this stuff is kind of interesting.
Animal transmission.
Yeah.
Like simian virus.
So specifically, what is it called?
SIV.
SIV, right? So simian immune deficiency. Primates mostly. Through the process of what usually? You guys remember?
No.
Yeah, you do. It's just the way I'm asking it. Like, how? How did it go from simian to humans?
Maybe evolution. Bites. Close contact with them.
Yeah, all of those things. So bushmeat trade, right?
Yeah.
So this is a virus that was living in primates for a very, very long time.
Yeah.
And as most of these viruses go, they can coexist in that host
Like the bird.
relatively fine, right?
Like the bird.
Yeah. Without doing much damage, but then it may not be the case if, through mutations or whatever, evolution, gain of function, and it'll behave different. So, and there was all kinds of different SIVs, right? Do you guys know anything about which ones were responsible for HIV-1 versus HIV-2, or is that? Yeah, see, I knew somebody was gonna. So those guys were responsible for which one? HIV-2, right? And then HIV-1 was what? Yeah, the common chimp, right? I think there's one of these guys in the San Francisco Zoo. You can go see. He's like all alone, poor guy in a cage, and known to have the original strains of HIV that were responsible for HIV-1 and the common chimp.
Still alive?
Huh?
Still alive?
Yeah. Mean that he's isolated in a cage?
Yeah.
It's like
I'm surprised he's still alive.
what do we
Yeah, it's all big
Perfect transition to my next slide. Look at that. First years. Name 4 antiretroviral drugs that are not Biktarvy. Huh?
What does Biktarvy have?
That's
Correct.
He's getting
So
smarter.
something
He's
that
getting
does not
smarter
have
than we were. He's getting smarter than we were. Don't worry.
What?
Choose that, which is something called the-
I can't hear you.
Trying that. What was it say? Primary.
Discovery.
So the SCOBY's sort of, kind of in Biktarvy.
It's like,
So that's.
It's happening.
All right.
One.
Just messing around. All right. So, but just know that there are other things out there. Okay. All right. So let's get into this. So, you guys have seen this before. So we'll go over it just because I think it's important to know, and I think that when I go over it in clinic, people don't know. So, and that's fine because you know this is why you're here. So, so first thing that happens. First step is you're binding to the CD4. The virus is binding to the CD4 cell via these receptors, right? So what drugs are going to work there? And you guys can see it, but just you can tell me. So what are we talking about there as far as like where the drugs are going to work in each specific step?
Entry inhibitors.
So we're still, yeah, exactly. Attachment. So your CCR5 antagonist and all that, right? So you're blocking that step. Then the virus has to fuse with the CD4 cell membrane. That's where your fusion inhibitors would work. And then what's that next step there that you guys see?
enters the cell, goes under reverse transcriptase.
Yeah. So do you guys know what those letters? The NRTI, NRTI. Okay. So yeah, they're gonna work at the reverse transcriptase, right? So you're trying to go from RNA to DNA, so that's where your reverse transcriptase inhibitors would work. And then what's the next step? So what's actually happening there?
Integrating the whole DNA.
What?
DNA.
Perfect. All right. And then after that, you come back out of the nucleus. What's happening after that? Of what? Yeah, so trying to put together exactly, right? And then assembly, and then budding maturation of these new viruses, and then that last step that got cut out of my slide, sorry, but that's where what group of drugs would work?
So after body.
Like when you're releasing mature variants now, you need this particular enzyme to be able to, yeah, exactly, protease, the protease enzyme. So that's where your protease inhibitors would work. All right. So basically, the point is these RNA viruses have a super high mutation rate in general, right? We've seen that with COVID. By the way, the whole talk about 10 years and asymptomatic spread, that's probably most viruses, right? I mean, asymptomatic spread is where it's at, right? That's we saw that with COVID. We've seen that with so many things. The more they replicate, the more chance of mutating. The more virus you have, the more you're replicating, and the more you can you're prone to mutations. This replication process is very error prone, right? Your reverse transcriptase enzyme lacks this proofreading activity, right? So a lot more errors, as opposed to like more developed higher eukaryotes, right? And I kind of said all that already. So basically, and then if you put drug pressure in, and depending on whether the patient's compliance, whether you have them on the correct regimen or not. So of course, the more fit viruses are going to survive and replicate, right? Depending on the drug pressure. Makes sense, right? All right, moving on. So just to compare, like the difference between, I think I showed this slide last year, but so HIV evolution in 1 year equals human evolution over 1 million years. That's how quickly we're talking about replication and transfer mutations, right? All right. So what are mutations essentially? Just what's another word? What's happening?
Changes that lead to different amino acids and
Exactly. So you're changing the genetic sequence in specific areas. So I think I've gone over some of this with you guys in clinic. And again, we're just going to show this because I think this is important. So You guys familiar with this, right?
Yeah.
So if we're talking about M184V, somebody explain that to me. You want to explain it to
So
me?
it's like you're taking for this M184, you're taking like methionine and it's replacing valine of the 184 position on the sequence.
Perfect. So the first letter is what's supposed to be there, and then the last
V is
letter
the actual-
is what's replacing that.
replacing.
Perfect. And then at the position, like you said, amino acid position on that particular enzyme, right? All right. So this is just again to kind of drive the picture home, right? So actually, why can't we get rid of HIV when we treat people? Why can't we cure it? So you're integrated to DNA, right? But your those cells or CD4 cells where the HIV already integrated into, they'll die off, right? Because otherwise, how does our therapy work, right? So what is it that's keeping it from completely going away?
Cells that are not really replicating.
Exactly. So and then what are those called? Huh?
Reservoir.
And like latent reservoirs, right? So because not some of the cells are going to die off, right? So essentially, with your antiretroviral therapy, what you're trying to do is you're trying to prevent those cells that have not been infected. So these are infected. We're not going to be able to do anything about that, but they'll die off, right? So you're just trying to get these activated CD4 lymphocytes, so they have to be activated. Trying to prevent those from getting infected, right? Makes sense. These latent ones we're not going to be able to do much about. These will die off. So you start somebody on antiretroviral therapy. These will die off. These won't get infected if you have them on the correct thing. Viral load drops, right? Okay. Viral load is equal to the number of infected cells, cells that are producing virus in the body, which we just saw how that happens in the whole cycle, right? All right. So kind of a different diagram, a different way to look at this, but basically, so you're treatment naive. You may have a mutation here and there, so you want to know about those. And then they could continue to replicate with that mutation. You put them on ART therapy, the number of cells in general are going to decrease, or infected cells in general are going to decrease. And then you can see here, this is just, again, just a diagram showing you what happens to become non-adherent. Then you may have even more cells with more mutations that are now spreading or dividing, right? Because that mutation will be selected out and it'll continue. Makes sense. All right, so this is just so you look at these, so you kind of have an idea of these groups, because we'll be coming back to them as we talk about certain things. All right, so again, just to drive the point home, I wanted you guys to kind of, I think it really helps, at least for me, it really helped me understand what's going on if I just dissect every single step, right? So for NRTIs, for example, right? So you're trying to incorporate into the DNA strand, right? So mechanism of drug resistance for NRTIs is going to be decreased incorporation of the NRTI into the elongating HIV strand, right? Because drug resistance mutation changed what you're used to seeing there, right? So those mechanisms of drug resistance for that particular step is going to be decreased incorporation or excision of that NRTI from the HIV DNA strand. So examples of these are what you guys know, right? NRTI mutations. Some 184V.
The K65R.
Which takes out what?
Abacavir, GDF.
K65R.
Abacavir, GDF.
Most energy.
Yeah, and the one that stands out the most when you see K65R. You guys said it already. Yeah. Just to make sure. All right. So, and by the way, these particular mutations are relevant for PrEP resistance as well, right? So, important for that as well. I think we'll move on. So I'll give an example for 2 of the groups and then we'll move on. So NNRTI, so kind of the same, but this is more of a mechanism of action here. So your drug is going to bind to a pocket of the HIV reverse transcriptase enzyme, right? So if you alter that pocket in any way, I mean, you guys have seen this in other things before, right? So if you alter that pocket in any way, you're going to alter the binding of the drug, not going to work as well, right? So kind of like a key and lock type of deal, right? You change that lock a little bit, and so that would give you an example of an NNRTI mutation that you guys need to know is this K103, right? And that takes out what? Favirenz, right? So when we used to have everybody on a triplet, that was pretty relevant.
You can use reproving apparently, right? With K103.
Yeah, and we'll get to that.
You're trying to get to the root of that.
That was a question we had on K103 on the ITE.
Yeah, it was on K103. Yeah. All right. So, and then last one, bear with me, and then we'll move on to better things, more fun things. So, integrase inhibitors, right? So the drug is going to bind to the HIV integrase active site, right? Same thing. You alter that conformation, and your drug doesn't bind as well anymore, so you're unable to you create resistance in that way, right? And an example of some of these mutations, there's more than this one, obviously, but I'm just throwing some out there. Have you guys seen this one before? R263K, so integration inhibitor, dolutegravir resistance. All right, so basically, this particular slide was, well, we'll do a brief summary before we move into the questions, but basically you want to target different stages of the virus, and I'll show you some studies that led to that in a minute. And basically drug resistance is going to happen. Your HIV is going to continue to replicate, especially if there's not compliance or other issues. And then you'll continue to replicate that virus. We've talked in clinic about wild type, getting the genotype, when to get the genotype, when it makes sense, when it doesn't make sense, right? And then it could be single mutations, multiple mutations, right? So this is just going to be my transition to this. So what is high barrier to resistance versus low barrier to resistance?
Just like good acquired resistance. Like high barrier, just like
and if we discuss that in the context of mutations, what does that mean?
It's looking at the less mutations that are like knocking out anymore.
Yeah, perfect, right? So it may only take one mutation for this drug to stop working, versus if you have a high barrier to resistance, it will take multiple mutations for this drug to stop, right? Okay. So within each class, and I can go back to, so within each class, it doesn't matter which one, it's just for the to make the point. So let's choose, let's say, let's take the NNRTIs. Do you guys know which ones tend to have a higher barrier to resistance versus a lower barrier to resistance within the class? Etravirine has higher barrier. Which one tends to have a really low? Yeah, why is that? So thank you for telling me what I just went over back to me. Awesome, you're listening. But there's other things that can come with that too. Do you guys know more about efavirenz? What is it about efavirenz, and especially using it in combo pills?
I think that it has a long half-life.
Yeah, exactly.
It goes down so long that you're sometimes getting like a very low drug level, so that it.
Perfect. There's nothing worse there's nothing more exciting for the HIV virus than monotherapy, right? So, so if
Good way to
you,
put it.
huh?
Good way to put it.
Yeah. So if your patient stops taking their pills and one of the components of that 3-pill regimen has a super long half-life, it's going to be monotherapy for that whole time, right? Make sense? So that also comes in, huh? Yeah. All right. So what about NRTIs? And this is important because if you happen to have a patient where you're like, I don't know what to do, I don't have any genotypes, they came with nothing, and you just have to choose something, and they've had some resistance in the past, then you're going to try to choose some of these sort of higher barrier resistance. Huh? Compared to the lower, which are who? And then which one you could argue would probably be even highest? Yeah, okay, good. All right, what about the protease inhibitors? What has the highest barrier to resistance? Which one has the protease inhibitors? Huh? So ritonavir is a booster, so that's not part of your regimen, right? Huh? Yeah. So the runavir has a higher barrier to resistance. A lot of these we don't use for other reasons, toxicity, right? Huh? See, that's why I want you guys sitting over here. I can't hear you. Huh? It's so important, your contributions. All right. Okay. Good. So those are your higher ones. And then what about, let's just do integrase inhibitors. And yeah, so then the lowest ones would be, and again, right, you can overcome some of these resistance mutations, and you'll see them with either dolutegravir or BID dosing on your dolutegravir. All right, so this is just showing you from studies that were done in a different way, in a graph, right? As far as a class, so now as a class, which drugs as a class have the highest barrier to resistance? INSTIs. And right up there, yeah, protease inhibitors, right? So then your NRTIs and NNRTIs being the lowest, right? With your NNRTIs being the lowest barrier to resistance. All right. This is kind of a silly question, but why do you think resistance is more of an issue now? Back then, why?
Less now, because there's more options.
Well, it depends. If you're treating someone who's had the disease for 20,
30 years,
yes. But if you have a new diagnosis, then it's pretty simple.
Well, it depends where that person got that virus from. So if the person got a resistant strain,
Well,
then you're dealing with a resistant.
but it reverts to wild
Probably in
It
the
does-
past, we had more medications, probably less adherence in the past, and saying to more medications. Like now, like we can prescribe this one pill and increase adherence for patients, but.
So that's part of it for sure. But what? Yeah, our drugs are just so much better now. We have so many more options. Our drugs are so much better. They're high potency, high barrier to resistance, right? It was, I mean, Dr. Matera can tell
Back in
you.
the day, we did monotherapy because we didn't know any better.
It-
We had AZT.
AZT monotherapy, I mean, that was, right. And even into the 90s, it was still, because they came with so many mutations, because they had been on, suboptimal regimens, right?
We're about the 30-year anniversary of PDOX,
Mid-90s, yeah, mid-90s.
Yeah,
So,
Actually,
mid-90s.
This is 30. It was just out here.
In fact, here's my slide. Look at that. So,
Kindly.
we did not plan that out.
yeah, that was the next slide to, Yeah, I mean, look at what was happening all the way into the early 90s. Look at that. Right? And at that time, I mean, even the thought of, think about how we treat other pathogens. Even the thought of having to use multiple drugs with multiple different mechanisms of action was kind of a foreign thought, right? So it took a while to figure that out.
Yeah, up until the early 1990s, a lot of patients were on single agent therapy, which obviously
Was not.
didn't work that well.
Yeah, in fact, let's talk about that for a second. Here we go.
And the combo agents, 3 times a day, 3 pills 3 times a day, with another one 2 times a day. It was a mess.
Not, which is what Celia was saying, that also patients had to take so many drugs that compliance was not great because of, and they were more toxic and less well tolerated, and so many reasons for that, right? All right, so this is an actual experiment that will drive that point home, right? So I just like looking at these older studies. So this was New England Journal of Medicine in 1997. All right, so if we take, for example, zidovudine with 3-TC, right? So that's this green one here. So the green, you can't really see it because it's kind of superimposed, but we started here, right? So you have a precipitous, I mess up that word all the time, fall of the viral load, right? You see that going down? And then we're not even at, what is this, like halfway through the 24 weeks, it starts to come up again, right? So your viral load bumps up again. What do you guys think is happening there? Your viral load drops super quick, and then, but it also comes back fairly quickly.
Maybe you kill off the wild type, and then the resistance strains start getting,
So which mutation would you, if you had to guess? Yeah, exactly, M184B, right? So then what's happening here? Why does it come back down again? Yeah, isn't that beautiful? This is a beautiful graph. So you guys know we talked about this in clinic too, whoever's rotated through and remembers. M184V, what does it do? So
lamivudine decreases as
if there's one mutation you guys need to know inside out, it's probably M184V.
Something else that can actually increase its ability to stop with your.
So
right. Decreases the ability of Bacavir.
yes, to a lesser extent, but yes. So you're taking out your 3-TC, Bacavir to a lesser extent, and lamivudine, and then what else did and then what else is happening? Because what's the terminology that we use there? Huh? We did go over that last year. I showed the same slide. There's like 5 slides that are the same.
Survival of the fittest batch.
But what are, like, if you're like, I'm an infectious disease doctor, I'm going to talk to you people about this. What words do you use, right? Because you can't just be like. Remember the more fit viruses replicate. So what is it doing? The mutation? So it decreases viral fitness overall, right? So you're making for less fit virus. Huh?
Resistance comes at a cost.
Yeah, exactly. Right? So that's important. So then you see that somebody mentions zidovudine. So it doesn't hurt zidovudine. It actually can make a couple of drugs work better, right? And you guys were getting at that, but what are those? And? Huh? Yeah, and zidovudine. Okay, good. All right, so, and then I think I have, well, I'll show you that in a minute. So let's take monotherapy, which is what we were doing. I showed you the graph of when the agents were discovered, right? So you're starting with monotherapy here with Denavir, orange. So again, falls down pretty quickly. it comes back up again, but you see how it takes a lot longer than it did with 3TC? Why do you think that is? Yeah, so and what did we say is happening when there's higher barrier to resistance? You need more mutations, right? So that's what's happening. You need, it's not just one mutation and boom, your viral load rebounds. You need multiple mutations, right? So you can kind of see that. That's why it takes a little bit longer. And then eventually the virus gets smarter, it's monotherapy, and then you still get your, do not get optimal suppression, right? And then lastly, your 3-drug regimen, right? We're starting with some of our first 3-drug regimens where you have a zidovudine, 3TC, and tenofovir, and that's your purple one here. And as you can see, but you get some viral load suppression, and it's pretty steady, right? Because you have multiple mechanisms, you can keep the patient below 500, right? All right, so that was that. I think I skipped a couple of things, but that's okay. So we'll come back to that. When do you want to get a genotype?
A couple weeks after we'll start there.
But also,
Prior to starting.
before you start, right? You want to know what you're working with at baseline, right? You want to know what mutations you're working with at baseline. Did they acquire an already resistant virus? What mutations are already there, right? So that's really important. You get it at baseline, and then so you said after so much time on therapy. Well, if your viral load is suppressed, then you don't, right? You're only going to get it if you're not getting your patient suppressed, right? But yeah, at baseline for sure. And then by guidelines, so before ARTIST started, following failure of a regimen, that makes sense, right? Because you're not going to be getting any genotypes or viral loads if your patient's suppressed, right? So failure of a regimen, obviously. And then when do you get a phenotype? Have you guys seen one of those? Huh?
They don't get them anymore, my God.
Yeah. Yeah, and
So
after failure of a third regimen, you should be thinking about getting a phenotype. All right. Huh? Yeah, I know. Or you just the art of medicine,
Yes.
right? But they're pretty cool, right? So this is what a phenotype looks like, so you guys can see it. So what do you think? I was supposed to block this and I forgot, but can you see? Tell me what's happening here and how this makes perfect sense with everything we just learned.
It's nothing. Well, yeah, M184 is basically decreasing your susceptibility to emtricitabine and lamivudine.
So you see that how this is drug susceptibility is decreasing to the right,
And some to.
but there's some things happening here to the left, right?
Right.
So what's happening?
Zidovudine and tenofovir are definitely.
Isn't that beautiful? We just talked about. So what's happening? Tell me the words.
Making the virus less fit.
Yeah. So you're decreasing viral fitness, and you're actually increasing the susceptibility of these two.
Interesting.
Right? And then we also talked about how it takes out lamivudine and emtricitabine and maybe abacavir, but to a lesser extent. Look at that. You can see it there, right? All right. So I skipped a couple of things here. We'll go back to that because it's a little more complicated. All right, let's start with putting some of these into. So 25-year-old, who wants to read it?
25-year-old man presents newly diagnosed HIV, had an episode consistent with acute seroconversion syndrome 4 months ago. Initial HIV viral load is 40,000, CD4 count 443. He wants to start ARV therapy. A baseline genotype is ordered that shows an M184V mutation. Which of the following drugs will have reduced susceptibility with this mutation?
It's not A and D.
Hmm?
It's not A and D. Because they're. Is that just?
Emtricitabine.
Yeah. So E. Perfect. Right. What were you saying?
I was saying it's not A and D because they're not in the same class.
Okay, got it. Gotcha.
Uh,
All right.
it's not-
Perfect. And then increased susceptibility we talked about, so I'm not gonna do that again. All right. Genotype shows an M184V and K65R mutation. Which NRTI drugs would you include?
B.
A.
A.
Why is it not? Somebody said another letter. I don't know who it was.
P65. All right.
Okay. So work through that.
So that increases resistance to tenofovir.
Perfect.
B, C, and D.
Huh?
B, C, and D get knocked out by K65R.
And your M184V will back of here, and then we just said everything goes up. So you guys, okay. So we don't have to go over that. All right. 34-year-old woman diagnosed with HIV 3 years ago, initially presented with PJP. These are her initial lab values. She was treated with this. The regimen failed after 12 months.
Sure. Yeah.
So what does the Q not?
Yeah, I'll go with that.
She's not confident I'm going
Let's do teams. Huh?
It's A.
Is that your final answer?
Yeah.
You guys are like, we don't know, so we're gonna go with Lauren. What? Oh, good. But yeah, it is. I had a slide with an explanation there. But yes, Q148. All right. There's more. I'm just gonna go through the questions and then we'll come back to them. I just need to watch the time. All right, who wants to read this?
32-year-old female presents to the clinic for evaluation. She's been on tenofovir and emtricitabine and efavirenz for 18 months. She admits to intermittent non-compliance and at this visit has a CD4 count of 198 and a viral load of 27,500. The genotype is done and reveals the following mutations. For nucleosides, it's M41L, D67L, and T215Y, and for non-nucleosides, it's K103N. Which of the following is the best choice for this patient?
So let's see. It's not a back of here.
Big target.
Big target. Big target.
It's not the emtricitabine.
Just careful with your natural impulse to just go straight to big target.
B.
Well, you also got K103N. So that's
Yeah,
gonna
so
take out efavirenz.
There's your fine, and then
I
C
don't
would
think
be a,
There's TAM mutations.
right, but then C would be simple regimen B.
The zidovudine and TAMs don't go well together. And then K103 will knock out efavirenz, so you're left with bictegravir.
So somebody did like the appropriate test taking strategy. You cross out A and you cross out D, right? Huh?
And C should be a
C.
as well as simple regimen.
All right. Can we get like 2 teams and then that way we can keep score? So,
Great, Cynthia's revenge.
huh?
Cynthia's revenge.
Sorry guys, I know it's torture. I mean, like. All right. So final answer is.
C.
Yeah, I was just trying to throw you off. All right, make sure you guys are sure about your answers. So good job. And yeah, exactly. You picked up on the TAMs. You picked up on. You could immediately eliminate A and D. And
What's that?
huh?
Thymidine analogs.
Everyone said Townsend. I was like, where does it say
Yeah.
Townsend?
So that stands for. You guys see that there? Thymidine analog mutation. I think you could answer this question without knowing what the TAMs are, and you don't need to know what all the TAMs are for your tests, for your boards. So you could, you could cross out the ones, and then, this regimen, which drug in B would not work for sure, even if you didn't know the TAMs.
A and D would not work.
Okay, so yeah, so I mean, you could narrow it down even if you didn't know. All right, so did I skip something? All right, this is kind of silly, but it was on your board review thing. So 32-year-old woman with HIV, treated with tenofovir, cytomine efavirenz. She's having rebound viremia. Her resistant profile shows K103N. Yeah, good job. This was also test taking strategy, right?
Yeah.
You can cross out a lot of things even if you don't remember what knocks out nevirapine, right? Even if you don't remember that, you can still cross out a bunch of things.
First line is useless.
Right, exactly. But K103N also affects nevirapine. So, all right. Okay, so this is gonna be. We'll let this team answer first on this one. I don't know how we used to do this, honestly, but it's HIV infected patient has resistance to most available antiretrovirals. A profile assay reveals 100% dual tropic virus. Which of the following best describes the use of maraviroc in this setting?
Yes. I think it's
D.
Because
It's only active against the R5 and they'll start mutating more against with the X4. So it won't be as dual tropic anymore. So you're just going to increase or not, I was on call resistance, but increase the tropism toward the X4.
So good. So you guys remember, so I'm glad that you changed your wording there. You guys remember the first part of the life cycle? Right? So this is not resistant. This isn't a resistance issue, right? Huh? Multiple, that's a good way to put it. So, right, I just want to make sure you guys understand that concept, right? This is, remember, how do we attach and what receptors, right? So if you have another way to come in, then there's no point, right? Okay. All right. Oh, I forgot about this. What do you guys? What do you guys? If you had to get HIV and you lived in a country with limited or no options for therapy, which one would you want?
None of them.
You have to get one.
That's democracy. B,
What?
I don't know. Vancouver. I'll take 2.
All right. Yeah, that's
Why?
a good answer, huh?
Okay.
Yeah, it's less virulent overall and easier to manage. All right. Oh my God, did that give you the answer already?
Yeah.
That's weird. Okay, we'll skip. All right, when do we want to add an integrase inhibitor genotype?
Always. Initial therapy.
Yeah.
They're like having to take it beforehand and they got acquired HIV, then you want again.
Carbapenem, PrEP, for sure. And then what else did you guys say?
They're failing.
Failing a regimen with an INSTI. What about a baseline? Other than that, other than the PrEP, which is good.
Like a newly acquired HIV, it wouldn't
Less likely.
it's high barrier to resistance, so if wild type, it's unlikely to have integrase inhibitor.
So this is something I would ask my patients and in my social history, and that could make me want to try, that could make me want to get this at baseline. So PrEP was definitely one.
Is if they've had sexual encounters with known multiple different HIV positive patients
So that's really
or people?
close. So like I asked them about who their sexual partner is, because they may have a monogamous sexual partner. If their sexual partner is a HIV positive partner and they're on integrase inhibitor therapy, right? That's another consideration for them.
Okay. That
Is
makes
this
sense,
not
then they acquired HIV.
part of the regular genotype that you get?
Correct. So that's good. That's a good point to bring that up. It is not in the regular genotype. You have to get an integrase inhibitor genotype.
You know something?
Yeah, I remember now. I just never ordered it.
Yeah.
Like,
Yeah.
I was like,
Because what's the rate of resistance generally speaking, in the general population for dolutegravir? Let's see.
I haven't seen one. Yeah. I haven't seen one, honestly.
Yeah. I was like, where is that?
I got burned.
You got burned.
Oh, really?
I got burned. That guy's resistant to every
It's the
instant.
whoa.
And that was the one he was transmitted to him.
Yeah,
wow.
so that's why we just talked about how you can get a baseline, right? And hold on, I have something from the last WHO. Here we go. So the 2024 WHO report on HIV drug resistance, right? So clinical trial data prevalence of INSTI-associated mutations among INSTI-naive individuals was less than 3%, but then some cross-sectional data, if people have been treated or in areas where there's high prevalence of resistance for other reasons, a lot of things that could, if you think through it, like things that could lead to dolutegravir standing alone, right? We talked about dolutegravir monotherapy, any of those situations where that could be happening because of failure of the other drugs, or because of whatever they received in the past. But yeah, it actually can be much higher, so 4 to 19%.
And you know how when people have HIV and they're non-adherent and then they have increased viral load, and over time they revert back to wild type, and the first time I acquire it from someone who's HIV positive, non-adherent with their medication on an INSTI, wouldn't you expect for them, if they're presenting a viral load of like 100K, to also have converted to a wild type? That's not passed.
Wait, what? Sorry.
Okay, so sorry. Like in patients who are non-adherent, let's say they're on like Biktarvy, right, and the regimen, and they're non-adherent to medication, and then you assume after 2 weeks maybe of them having increased viral load, that at one point the virus will revert back to the wild type for increased fitness.
I see.
The same argument, could you argue that if a person acquired HIV from a known HIV positive partner who's also non-adherent and also has high viral load, that the patient who acquired the HIV, if they've been viremic for some time, also will revert back to like a wild type form of the virus?
Yes.
Or not, because the one they acquired wasn't the wild type, and patients who have both.
Correct.
Right?
So you're talking about a scenario in which you acquired already resistant virus.
Right, which is
So when the
different.
virus is multiplying in you, it's multiplying with that mutation. It's carrying that mutation
But
forward.
you still have some
Right?
of the other.
Because that's how it came in the first place. Wild type, we're talking about you came in with this, which may not have had any mutations, or maybe maybe like a K103N was one of the more common mutations back, right? The higher prevalence, it was like 30% because we were putting everyone on a triple, right? So you came in with that, and that's your wild type, right? So that's already your wild type. Then you put them on drugs, and the drug pressure may change or add or do different things. So then you want to check again for a different reason. Does that make
It's all
sense?
about the drug pressure.
Yeah, that makes
right?
sense.
Yeah.
Okay,
What
makes
you're
sense.
manifesting is
Right.
always a reflection of the blood pressure
That
or
makes
the
sense.
lack of drug pressure,
Okay.
which is why if the person has been off their antiretrovirals for more than 4 weeks
Yeah,
or so, then you're not going to be seeing the effects of that.
right. But it's also because they still
But
have
but
what
but
they acquired from their
what they were
baseline.
asking was
Yeah.
about somebody who already came in with mutations,
Yeah.
and reverting to wild type is not wild type as we think
Right,
wild
Right,
type.
that makes sense.
It's not a true wild
At that
type.
point, so you never
It's
have that.
it's you already came in with an integration inhibitor mutation.
Even if the genotype would show wild type,
Yeah.
like you said, they always carry those strains with them from the prior
Right.
pressure. And
Okay.
to show up on genotype, you need it to be a significant percent, like at least 10% of strains need to show that mutation. Otherwise, you won't
Okay.
catch it on genotype. But it still
Okay.
can be circulating and it still can be
We
transmitted.
should probably stop using the term wild type when we talk about that situation. Because
Yeah.
it confuses us.
And that's what I wanted to
Yeah.
clarify, which is it's not your
Relative.
traditional wild type when you think of your traditional wild type, because it already came in with mutations. Your wild type is your integrase inhibitor mutation, right?
Thank you.
Their base, yeah, exactly. I guess their baseline wild type. I don't know. All right. So we just discussed about this.
Right, yeah.
All right. Okay, here we go. 40-year-old patient with HIV infection receiving a bacterial boosted darunavir has not been maximally suppressed. Genotypic resistance profile shows this mutation. Which of the following drugs would maintain activity?
Tenofovir.
I think so.
Tenofovir.
Final answer?
Yes.
All right. Good job. So resistance to all NRTIs except for tenofovir. All right, and we'll have like a little summary side. I don't know how much. Do I have like a couple of minutes or? Let's see. I'm gonna try to get to
1 minute.
1 minute. Okay. Yeah, I'm gonna skip that. All right, we can try this one, I guess. 54-year-old long-standing HIV, viremia, on 3 prior regimens, currently on boosted atazanavir. Genotype shows these mutations. This is all board stuff, right? I mean, it's kind of. Huh?
And if you have a lot of questions left, we can do a second part in June.
Yeah, I'll do the board review in June, but I'm just gonna do a summary slide after this. Yeah. What? So process of elimination, you would take out what?
The bacteria. Hepatitis B, zygote.
as well, because it says
And we know with the other, like, K65R and 184V, just process elimination, the only thing left is AZT.
Right.
Yeah, basically, right? So M1A4V took out your lamivudine, emtricitabine, and abacavir to a certain extent. K65R took out what?
All except AZT.
You guys said? Yeah, so again, somebody was saying over there, not real life, but this is how they test you on your mutations. Because we don't have anyone on AZT except a handful of VA patients still. Actually, I think we transferred all of them to, we transitioned all of them to, but they were kind of married to their AZT and didn't want to let it go. All right. So I can send you these so you guys can screenshot what you need to know for your boards, but we'll do a board review in June. So these are the main things for you, the main ones for you to know, which are the ones we kind of went over most on the questions. For real life, then it gets into
If you know these, you should pass
a little, yeah, you should get, they're high yield, super high yield, right? Because this is a little too much, but this is more for you guys to know in general, that be familiar with these. That R263K is really troublesome with the dolutegravir. This would probably be also important for knowing how to do therapy, but some of the key ones that we mentioned for the boards. But I would say that this is what you need to know for the boards right here.